Well, thank you so much, Dr. Rani. We'll share our screen now in our presentation. Yeah, we're really glad to be able to share our work with you in this seminar. And today we'll be presenting the research that's really highlighting use cases that we've employed using methods of data processing, analytics, and machine learning on electronic health record and social determinant data. And we formally began this research last spring with the CDH, and we've been working on it throughout the summer and on.
Wait, you have to clip it. There we go.
All right, so I'm Robbie Felton. I founded this project. I'm studying public health, rising senior, but I'm taking a gap year to focus on continuing this work.
Hi, I'm Isabella Henderson. I'm the clinical research lead here. I'm studying health and human biology. I'm also a senior, and I'm from Massachusetts.
And I'm Will Mims. I'm the clinical business liaison. I'm a current senior at Brown studying behavioral decision sciences and economics, and I'm from Asheville, North Carolina.
So we're going to pop off. We're going to let Robbie do the first part. Thank you.
Our mission at Intus Care is to empower long-term care providers through data to deliver more effective care to older adults. And we really want to let long-term care providers know who their highest risk patients are for hospitalizations and negative health events, why they're at risk, so they can prevent or put in place preventative interventions to improve patient outcomes. To start, we will give an overview of what we do at Intus Care. Next, we will detail the methods, results, and discussions regarding our two studies. Then finally, we will provide future implications and make note of important people supporting the success of our team. In the Journal of American Geriatric Society, it has been cited that 39% of hospitalizations are potentially preventable for older adults, dual eligible for Medicare and Medicaid in forms of long-term care. We believe that this is in part due to a lack of resources for meaningful, effective data usage for long-term care providers. The Center for Medicare and Medicaid Services, CMS, defines potentially preventable or avoidable hospitalizations as admissions for acute illnesses like pneumonia or UTIs and chronic conditions like COPD and CKD that could have been prevented through measures in an outpatient setting. And now I'll pass it over to Will, and he will present part one of our study.
Yeah, I'm going to take my mask off as we do this social distancing in here so I can actually speak a little more freely. Yeah, so part one of our study today will outline Intus Care's model for risk stratification and cost forecasting using machine learning for long-term care providers. So essentially this study will outline Intus Care's targeted intervention for issues associated with preventable hospitalizations in long-term care. So starting with our sample, we used 500 dually eligible patients and over 3 years of data from January 1st, 2017 through June 1st, 2020. The sample contained a high proportion of racial and ethnic minorities, socioeconomically disadvantaged individuals, and patients with multiple chronic conditions, all who need high levels of nursing care. Unfortunately, due to our current partnerships and HIPAA confidentiality requirements, we are unable to reveal any additional information relating to our sample or organizations we have worked with in order to attain this data. So starting with methods, we used data processing and machine learning on electronic health records, or EHR, to risk score patients and identify costs associated with potentially preventable hospitalizations, or PPHs. These risk scores were taken and stratified into 4 groups: low, moderate, high, and highest. We also added an additional group in order to place these patients that did not have enough data for accurate stratification, and we labeled that group insufficient. Our machine learning models were initially trained on all available data that we had from 2017 through 2020 to create a baseline and kind of hone accuracy. The models were then tested on a training set of 2018 ICD-10 codes, and these are basically codes to classify diseases. And we did that in order to predict patient cost in 2019. So finally, through similar risk stratification and automated data processes, we identified ICD-10 codes associated with chronic kidney disease and then completed a sub-analysis on the affected patients of our sample. We'll dive into that sub-analysis later on. So to provide a more granular step-by-step outline of this process, we start with an initial electronic health record integration, automatically extracting things like social determinant data, patient health history, claims data, basically all the relevant factors from the EHR. The automatic data extraction really eliminates the need for manual entry, which helps in accuracy, obviously, and comprehension. Then using the extracted data from the EHR, we ran algorithmic analysis through the machine learning algorithms we have, the Intus acuity risk model. So we combine the comprehensive data with these machine learning models. We were able to create individual patient risk scores, CKD analysis, and organizational level reporting. And this was all done in order to reach our goal of reducing preventable hospitalizations. So diving deeper into the AR model, we developed a machine learning risk grouping algorithm for long-term care patients. So the acuity risk model, or AR model as we have coined it, has over 100 separate diseases, conditions, and social determinant of health factors to accurately risk group these patients. So the purpose of the model is to leverage machine learning and social determinants of health to predict, reduce, and improve potentially avoidable hospitalizations and their corresponding costs. This comprehensive approach will really help improve care outcomes and mitigate unnecessary costs regardless of social or economic status. So moving to the results of this study, a very impactful kind of overarching result was from the prevalence of potentially preventable hospitalizations and then the expenses that came with that from the sample. Our results showed that 27% of total external utilization events in long-term care patients were deemed actually potentially preventable. So these external utilization events included inpatient and outpatient services, acute hospitalizations, ED visits, and ED visit transports. ED visits are emergency department visits. From our sample, these utilization events led to a loss of over $300,000 per 100 patients, actually every single year. So breaking down the results of the preventable hospitalizations by risk group, we identified the top 2 risk categories, high and highest of the 4 categories I mentioned earlier, as contributing to over 85% of the total preventable hospitalization costs. So the average cost per patient also provides a really clear look at the association between the top 2 risk categories and their preventable costs. The highest risk category was costing on average over $10,000 per patient per year. And then the highest risk category was actually costing over $18,000 per patient per year in preventable expenses. So moving to the results from our AR model, cost forecasting and AR model, we were able to predict the annual cost of patients in our sample given their ICD-10 codes. So looking at the scatter plot here, on the left side, the y-axis represents the predicted cost for patients, and the x-axis represents the actual cost. So each plotted point is a patient, and every point on the line represents an accurate cost prediction by the algorithm. So if you look right here, every single point that's on the line is accurate. Every point that is above is a patient that was more expensive than the prediction, and then every patient below was one that was less expensive than the prediction. So overall, the majority of patients are clustered around the line, which represents an accurate R-squared. It's represented by an accurate R-squared of 0.082. And this indicates that our model can forecast cost really effectively and thus helping in predictions. So to briefly draw your attention to the table, this is just summarizing the statistics of the predicted patient costs, all represented by the graph. So we also completed a sub-analysis on patients with chronic kidney disease, CKD, who are known to be a particularly high risk for healthcare utilization. So our study found a considerable number of patients in the sample with high predicted costs and high risk for CKD onset or exacerbations, all who were not previously identified as at risk or diagnosed with CKD. So the results of that sample, the results from our sample, not of the patients that were not already diagnosed with CKD, we found a significant number showed multiple risk factors that associated with the development of the disease. For reference, these factors include but are not limited to diabetes, which is one of the most common factors associated with CKD, morbid obesity, congestive heart failure, high blood pressure, and several more. Showing this, you can look at these bubbles. We have 39% of non-diagnosed patients were at moderate risk with 4 more risk factors. And then of that 39%, 27% were at high risk with 4 more risk factors, including diabetes, which is one of the most commonly associated factors. And of that subset, 9% were actually at the highest risk for CKD with 6 or more factors. So CKD is a really good example to use for this, as it can cause severe health problems, and the annual cost of treating the final stages of CKD is on average $72,000 every single year, $72,000. So moving to readmission results, from our sample, our model was able to accurately predict 53% of 30-day readmissions based on what the patient profiles were at the discharge from the hospital. So to briefly go through this table, looking from left to right, we have the type of statistic measured, the found value, and then on the far right, we have the 95% confidence interval of those values. Our sensitivity statistic represents that of the readmitted patients, 74% were categorized as high risk, while the specificity statistic shows that 47% of non-readmitted patients were not categorized as high risk. The positive predictive value, or PPV, provides a good reference point, as it is showing that those who were categorized as high risk had a readmission probability of around 30%. So to summarize, coming back to reiterate important findings, our machine learning models proved successful in accurately quantifying preventable expenditures, accurately predicting annual cost of patients, successfully flagging patients at high risk for CKD onset, and then risk grouping those patients accordingly. And finally, predicting patients at high risk for being readmitted to the hospital based on their discharge patient profiles. So in conclusion, we will continue to do our running machine learning models as we acquire more data. And through this training process, our models will progressively actually get better and more accurate the more data we have. The implication from these goals and from this work is to provide powerful data capabilities to long-term care providers. So through these data empowerment tools, providers can improve patient outcomes and address problems associated with preventable hospitalizations laid out throughout our presentation. So thank you for your time. We will now transition into part 2 of our presentation with Isabella Henderson.
Hello. Okay. Hi. Let me take my mask off. I'm in the zone. Hi, I'm Isabella Henderson. I'm going to be talking about social determinants of health and how we use race and ethnicity and zip code risk to explore disparities in disease rates and external utilization, and also with that external utilization, those preventable costs. So social determinants of health, so they are defined as economic and social factors that influence differences in health status. This is both at an individual level and at a group level. And social determinants of health, also called SDOH, they don't rely on symptoms or genetics. It's about explaining underlying causes of disease in the context of environments that are largely outside of personal control. So social determinants of health are largely, they're very closely tied to health outcomes, and they can have significant influences over health status and especially care access for certain populations. So as we see here in this diagram, healthcare access, community and social context, food, that's nutrition and access, education, neighborhood and physical environment, which is also crime, and economic stability. These are all really important factors that influence health positively or negatively. And I actually want to talk about the phrase social determinants of health really quickly. It's actually starting to be changed in academia to emphasize influences over determinants. And the reason why is because potentially negative effects of environment are probabilistic rather than deterministic. So determinants can make it seem like there's no room for resilience, for agency, or for effective interventions. But for the purposes of this literature, we're going to still be using that term. It's still the accepted term right now. Okay, so let's define disparities. So when social determinants of health affect a person or a group negatively, it can create a health disparity. So health disparities are preventable differences in disease burden or opportunities to achieve optimal health. These are experiences by socially disadvantaged population groups and communities. So the two important health disparities we're going to be talking about are race and ethnicity and zip codes. So race is often intertwined with socioeconomic status. It can go along with physical environments such as poverty, violence and crime, and housing, as well as access to care. And meanwhile, zip code is also an indicator of many different environmental and demographic social determinants of health. And it's commonly cited that a person's zip code can actually be more indicative of health than their genetic code. So for these groups, health disparities may take on many forms, including high rates of chronic diseases and premature death. But when you're looking at long-term care, a comprehensive overview of disparities and care access is really crucial for equitable care and also service delivery, especially because interventions that are directed at high-cost patients actually may under-target racial and ethnic minorities, because these groups have been shown to have relatively lower costs but worse clinical outcomes. So first, we're going to define zip code risk. Zip code risk is one of the metrics we use to look at our sample population. We use something called the Social Vulnerability Index, or the SVI. It's from the CDC and the US Census Bureau. And it specifically ranks zip code tracts and even census tracts by percentile risk of environment. So they use factors such as housing, educational attainment, race, ethnicity, language, transportation, access to services and healthcare, everything like that. And it gives us a very specific zip code risk ranking for the areas where our patient sample lived. So this meant that we could stratify every patient into a category corresponding to the overall risk of their areas. And these categories, they're from the SVI, and we also use them in our research. It's low risk, low to moderate risk, moderate to high risk, and high risk. Okay, so starting with methods, we first performed a data extraction from the electronic health records, and we did this from January 1st, 2019 to December 31st, 2019. Our data pipeline used ICD-10 codes, clinician notes, general EHR, and hospital records in order to identify our variables. Next, we used that SVI index, like we just previously talked about. The third thing we did is we measured disparities by using the most socially favorable group as the referent and comparing it to other groups of interest. So for race, we used white as the referent category, as non-white populations have worse health outcomes in the United States. And for zip code, we use low risk as the referent, as those in lower risk neighborhoods and environments are proven to have better health outcomes. So next, we extracted potentially preventable external utilization costs. Using those same potentially preventable lists cited by the Center for Medicaid and Medicare Services. And we calculated cost disparity as significant difference in the cost from the referent. And then finally, we used risk ratios, and we used a multivariable logistic regression model. We used a 95% confidence interval, and we also used a standard normal deviate and a p-value just for significance. All right, so I'm gonna go over the patient sample in a bit more detail. So we took our important social determinants of health, which was race, ethnicity, and zip code risk, and we used multiple variables in order to identify trends within our patient sample. So again, because of HIPAA and confidentiality, we aren't allowed to release the exact numbers of patients in each group, but we do have the percentages, so I'll just highlight some of the important things. So for zip code risk, the high risk zip code group was the most populous, with low to moderate next, and low risk being the least populated group, with only around 10% of participants residing there. Within these groups, the high risk zip code group is primarily Hispanic, and we use the term Hispanic because that was actually the term found in the patient's EHR. The moderate to high group is primarily white, but the low risk and low to moderate risk groups are really primarily white at about 70% white. And so for race, white is the largest group at about half of the population that we were using, followed by Hispanic patients and then Black. And then our Asian population had a very small number of people. The majority of non-white patients resided in high-risk zip codes, compared to only about 24% of white patients. And then we have these other and unknown groups right here. And these groups are used to describe patients with races or ethnicities of too small of a sample to be de-identified in the research. And also we had about 5 patients that actually had no race or ethnicity listed in their electronic health record. So for our variables, we used chronic diseases first. And these are 4 of the most prominent chronic diseases in long-term care. So we have diabetes, especially type 2 diabetes. We have CKD, which is chronic kidney disease, and ESRD. And we put those 2 together because CKD progresses to ESRD in long-term care patients. And ESRD is end-stage renal disease. We have congestive heart failure, which is actually one of the top causes of readmissions. And we have chronic obstructive pulmonary disorder. So external utilization, we included emergent or urgent events. So we use things like acute hospitalizations, which meant that one person could have multiple events of interest. We also used patient hospitalized, so that was a binary variable, so only 1 count per person. We used readmission rates, and we used ED visits. And lastly, we looked at total cost per person, and then the cost of potentially preventable diseases and the cost difference from the referent. So here are results when we tabulated our sample of patients by their zip code risk. And I will say that some of the patient incidences and prevalences have been removed for anonymity, but these are our zip code outcomes. And I know this is a very overwhelming kind of graph to look at. We're gonna break it down. Just for clarification, anything highlighted in orange is gonna be a high rate that we wanna pay attention to, and the yellow is gonna indicate a lower rate. So actually we had no significant differences in disease rates among zip codes, which was very interesting. For total costs, we're just gonna jump down there. Again, total costs are all external costs. All groups cost more per person than the referent group. So moderate to high cost significantly less actually than the low to moderate or the high groups, which was interesting, but they still all cost more than that low group, which was the referent group. And so theoretically, you'd rather more at-risk groups cost more than the referent because the referent is comparably more socially advantaged. So this was cool. For our preventable costs, you can generally look for many things, but we were looking for more of a uniformity. So if everyone's having way higher preventable costs, you know, that there's room to be improved and there's room for interventions, but also higher costs for higher risk groupings is common as preventable diseases disproportionately affect high risk groups. And so here we do see that the moderate to high group is having less preventable costs per person, while the other groups are having greater. And low to moderate here has actually a pretty great preventable cost per person. So we're just gonna break down the utilization statistics from the zip code risk. So when we look at patients in high risk zip codes, the ED visit rate was 615 visits per 1,000 person years. And just to clarify, we're using person years for these rates because the Center for Medicare and Medicaid Services, when they do similar calculations and studies on external utilization in long-term care, these are the metrics that they're using. So anything in red is going to be the highest rate or number for that category, also a clarification. So again, 615 per 1,000 person years, which was the highest ED visit rate for any group in the zip codes. People in high risk zip codes are also having 41% of them were hospitalized at one time during that year. And their readmission rate was 35%, which was also a very high readmission rate. And so now we look at the low risk zip codes. You have only 176 per 1,000 years as the ED visit rate, which is much lower. Let's see. You have a 12% readmission rate, but you're also having the same rate of hospitalization. So within that low risk group, the same percentage of patients are going to the hospital, but they're being readmitted way less. So this indicates that you're still being hospitalized at a high rate, but you're potentially getting better care as you're not being readmitted as frequently, and you're not going to the ED as much. Okay, so jumping to race and ethnicity outcomes. So I want to draw your attention to how different the colors are looking in this data. We have a lot more differences in disease and utilization rates, but before we dive into the significant data, I do want to point out some areas of interest. So first, we had actually no significant differences in congestive heart failure prevalence by race and ethnicity, but we did see that white patients were significantly more likely of having COPD than non-white patients. And here's where it gets interesting. So for total costs, all non-white groups had significantly less expenditures. For preventable costs, the same phenomenon was occurring. So even though non-white patients are having higher rates of potentially preventable diseases, these at-risk groups are having less overall costs and less preventable costs. So for significant outcomes for our Hispanic patients, Hispanic patients were 1.47 times as likely to have diabetes and 1.47 times as likely to have CKD or ESRD in comparison to white patients. The Hispanic ED visit rate was 590 visits per 1,000 person years, which was the highest for race and ethnicity. But the amount of patients who had an acute hospitalization was 41%, which is actually the same number as both the low risk zip code and the high risk categories from the previous slides. And then let's investigate our Black patients. Black patients were 1.45 times as likely to have CKD or ESRD. This is a very high number with our sample. Their ED visit rate was 441 per 1,000 person years, which was actually relatively low in comparison to our other groups. And just to cement this, Black patients were 40% likely to have less likely to have a hospitalization compared to white patients. So you see an overall lower utilization trend here. And so when we talk about our white patients, which was our referent group, their readmission rate was 33.13%. This was very high. This is the highest we saw. The hospitalization rate for our white patients was 458 per 1,000 person years, also the highest. And you're having about 57% of all white patients were hospitalized at least once over that year. So white patients are actually having the highest rates of utilization in all metrics except for ED visits, where Hispanic patients have the highest rate. So yeah. So just in summary, this is just a forest plot of hospitalization ratios along with their 95% confidence intervals, just so you can visualize kind of what this means. So the first 3 points are the zip code risk groups with the low group as the referent, and the RRs are, they're above 1, but their confidence intervals are very wide and range from about 0.75 to over 2. So it's hard to say with 95% certainty that these values would accurately represent the population. And then when we look at race and ethnicity groups with white as the referent, the RR values are well below 1. So that would indicate less hospitalizations. And if you look at, some of these confidence intervals, they're a lot tighter. In the summary, there were no significant disease rate disparities within zip codes. There were disease rate disparities within race and ethnicity groups. Utilization was higher for high risk and low to moderate risk zip codes. And utilization and costs were higher for whites. So just a bit of a discussion. So the first thing is that patient zip codes were likely not salient or predictive risk factors. Geographic access to care may have really affected utilization. So high-risk patients had the overall highest rate of utilizations for this category, but since many high-risk zip codes were located in urban areas with high densities of hospitals, these rates may have resulted from an easy and local access to care. Inversely, low-risk zip codes were more rural and farther away from hospitals, and a low rate of visits in the referent group would also explain the results. Additionally, white patients actually made up a large portion of the low to moderate risk group, and they had very high rates of utilization. Second, cumulative disadvantage theory. So this theory really states that early advantages or disadvantages are crucial to the contribution of inequalities and give rise to later trajectories. So race and ethnicity and zip code are both early risk factors with the potential to shape long-term outcomes. And the effects of these factors really accumulate over time and over the lifespan. So this may increase differentiation and compound risk for certain demographics. And accordingly, although disease risk and burden disparities were observed in our sample population, the results may be due to an accumulation of risk and disadvantage, as it probably should be, but over time, rather than a direct or indirect effect of a long-term care organization. But the important part is that if populations are affected by cumulative disadvantage and not necessarily the care itself, then if we want to make sure that all patients are getting the same care, we need to continue to use things like machine learning and data technology and risk grouping in order to provide that best support and acknowledge social impacts. And third, we're talking about overutilization or underutilization, which is a utilization bias. So multiple variables may contribute to race and ethnicity utilization disparities. So some interpretations about that would be that one, white patients could be overutilizing. White patients could be going to the hospital more, just utilizing more. But another thing is that white patients could just be getting admitted to hospitals more. They had a very high rate of hospitalizations, and it could be that when they do go to the hospital, they are admitted at higher rates. Inversely, non-white patients could be underutilizing, and there are many explanations for that, that it could be due to discomfort, distrust in the system, past bad experiences. And also non-white patients could not be being admitted as a higher rate or as encouraged to go to the emergency room, except for Hispanic patients that had that really high rate. So again, research does show that interventions directed at high cost patients may under-target racial and ethnic minorities who do have lower costs but worse clinical outcomes, which we kind of saw today. All of these interpretations could be possible, or there could be factors unconsidered by this study. It's social determinants of health, so it could be a whole combination of everything. So I'm going to hand this back over to Robbie to kind of take us on some future implications.
A logical continuation of our studies is essentially to combine the predictive aspects of machine learning in the first section of our social determinant related risk, cost, and outcome analyses with the second section. In practice, this would allow us to support long-term care providers in implementing targeted interventions to address social determinants of health in a data-driven manner. Immediate next steps for Intus Care are to conduct additional studies within long-term care to improve and further our methods and results. Additionally, we would like to do the same with hospitals or health systems to identify similar metrics across the care continuum for older adults. For long-term care organizations and potential pilot partners, we provide similar insights and more through our cloud-based web application for usage by administrators, care managers, and providers. Feel free to find out more at our website, intuscare.com, or you can email me directly at robbie@intus.care. And in our last slide, we would like to acknowledge the participation of and help of our advisors and additional contributors as listed. I would also like to acknowledge the support that we received from Dr. Rani, as well as the Center for Digital Health. And thank you very much for all your time and attention.
Great job, you guys. Thank you so much for this excellent presentation. I saw some good questions going in the chat. So what I'm going to do is I'm going to open it up for Q&A now. We can start with some of the questions in the chat, and then I encourage people to just unmute and ask your questions. I think of this both as an opportunity to ask questions about the science as well as about the model, and for us to give some great Brunonian feedback and guidance to this terrific team.
Yeah, so I can go on the first one. External utilization to what? The health system. A lot of these care organizations and long-term care facilities do a lot of their stuff in-house. So external is external to what the long-term care organizations cannot do, such as inpatient and outpatient, such as acute care and emergency department visits and emergency department transport. So it's external to the long-term care facility.
Mm-hmm. And then we can go to how are preventable costs defined. So preventable costs are anything like we were looking through claims data and the electronic health record. So anything tied to the ICD-10 codes that were potentially preventable as deemed by CMS are things that we use as preventable costs. I think those are the only questions we can see right now in the Zoom chat. Oh.
Yeah, if anyone, welcome to unmute and just ask. Yeah, feel free.
Since you already answered my questions in the chat, I'm curious as to what your thoughts are on how to operationalize this type of risk rating and how long-term care directors of nursing and administrators might be able to take advantage of this type of analysis.
Right. So I think one of the strongest use cases is for whoever the care manager is for a specific patient. So knowing a patient's specific risk can help in their care planning. So knowing, oh, this patient might have be due for a CKD related assessment sometime soon, or let's say at a hospital discharge level, let's say a nurse gets a notification that this is a high readmission risk patient and you should provide some additional services to them to keep them from being readmitted.
Yeah, a concrete example would be someone, like imagine someone has fallen a lot in the past and they've been falling a lot in the last 2 weeks. That's not really being reported anywhere. So in the risk category would be, oh, they're high for falls. What can we do to try to prevent that? We can maybe bolt down the furniture, remove rugs, kind of having that information that they're higher risk for falling. You can, like Robbie said, apply preventative medicine and kind of prevent this stuff from happening before it happens.
So I could be wrong because I'm not an expert on this, but I don't think there's an ICD-10 code for fall risk. How are you all tracking it?
So there's an ICD-10 code for falls and also for frequent falls. So we track it that way. We also, within a lot of EHRs, there are independent tabs that care organizations use to keep track of falls, and that can also be used.
Thank you.
And I should have said, Laura, do you mind just introducing yourself? It would be great, since not everybody knows each other. If people could just, as they're asking a question, provide like a one-liner about who they are and where they are.
Sure. So I'm a healthcare entrepreneur based in Chicago. I'm co-founder of a company called Huku AI. We're a patient-centered messaging hub, and our customers are post-acute care physicians, groups, nurse practitioners, and long-term care facilities. So we're super interested in what you're doing and would love to talk about how we might be able to collaborate to help improve the quality of care in post-acute care.
Amazing.
Great.
Yeah, we would love to follow up after this and connect and speak further. I see that it says someone raised their hand.
Hi. Great talk. My name is Adil Abbasi. I'm faculty here at Brown in the Department of Emergency Medicine and in the ICU. So we already have inbuilt warning into EPIC, which is our EHR here, where they sort of give us a score of how likely someone's going to be readmitted when it comes time to discharging them. Do you know what they base that score on and how that differs from the models that you guys have created?
Right. So I know in EPIC, from what I've seen, they use Charlson and Rothman index, which are pretty strongly based around just comorbidities. Ours includes social determinants and also includes this like predictive aspect that can really tailor itself towards a specific patient population more. So it's training on your specific patient's data. So there might be environmental risks within your area that contribute more so to the risk, while those specific models are more static.
Mhm.
Additionally, in the end of like, those are things kind of pre-built into EPIC, like in the aspect of this, when there's a kind of an external tool, it could, let's say, send a notification to whoever your discharge planner is for a patient and tell you why they're specifically at risk, and help your planning process and help you put in preventative measures, so to speak.
So to clarify, does your model predict who's more likely to be readmitted after being discharged, or who will be unnecessarily admitted in the first place?
So we actually have a one model that's specifically for hospitalizations. So which patients are likely to be hospitalized or have a hospitalization over a certain period. And then we have the readmissions model, which is specific for 30-day readmissions post-discharge.
Yeah, just to reiterate from the presentation, the model that we tested through the first study, 53% of, we were able to accurately predict 53% of 30-day readmissions.
Post-hospital discharge.
Post-hospitalization.
And did you guys do a corner analysis to see the 47% that you weren't able to predict?
That's something that we're doing in our next steps. So
we're continuing that research.
Great, thank you.
Thank you.
So quick question, since the topic of EPIC EHR was raised, the data that you automatically pulled from the EHR, was that pulled from the long-term care's EHR or EPIC, the hospital's EHR, or both?
So it specifically was pulled from provider-specific electronic health records, not from the hospital.
And so what system was that you were able to automatically pull that?
Yeah, we actually can't share that.
We have HIPAA confidentiality stuff. We have to can't answer that.
But in terms of it was a long-term care specific electronic health record. Yeah, and in terms of our system, we were also able to pull from FHIR interoperable electronic health records as well.
Yes, I have a question. How perishable do you consider your data, and how often do you plan to update for future evaluation?
Mm-hmm. So for us, we were pulling on twice a week to update our systems, but we can pull as frequently as anyone would deem necessary to have accurate risk predictions. So currently we're basing it off ICD-10 codes that are picked up at appointments. So doing it on a weekly basis is sufficient, but let's say we started getting lab work and let's say vital records that are collected at a more regular, on a more regular basis, we could update, let's say, daily.
Yeah, we could basically update it as quickly as we need to, as frequently as
Thank you.
Good question.
Do you mind just introducing yourself and where you're from, just for the sake of all of our participants? I think you're listed as being Liz Rupp on Zoom.
That is actually my grandfather.
Oh, it's your grandfather. Well, that's awesome.
That's so cool.
So you took care of it. Thank you.
He was from Asheville, North Carolina as well.
That's awesome.
I had another question if no one else does. do your methods allow you to do this prospectively? I think, there's been a lot of people looking at this, but I haven't seen that many prospective studies where you take a cohort of, 1,000 patients or so, predict who's going to get readmitted after they get discharged, and then see how many, in fact, get readmitted after being discharged.
That's something we're actually currently working on with some of our pilots. But we'd love to, if someone has a patient base that, or an organization that would be willing to like partner in a study like that, we would be very, very interested in running tests such as that. So if you're connected with anyone who could set us up with something like that, we would be very, very interested.
And are you partnering with any clinicians to develop clinical paths that might reduce those readmissions?
That's also another next step. So we're trying to build out a clinical advisory team to do such. So we've been collecting best practice interventions from across the long-term care space and from different geriatric healthcare facilities. And so we have a pretty concrete database of that, but we really need the clinician aspect and their insights to further what we're doing.
So I'm going to ask, unless I want to let other people ask questions, but if they don't, I'm going to ask a non-science-based question.
Please.
Okay. So as you know, one of our goals at the Center for Digital Health is to help facilitate this type of innovation and growth. And, we do it through collaborating with the rest of the Brown community. So I would love your reflections on, I know you've been in existence for about 2 years. If you could go back and start Intus again, what are the big learning points that you've had in terms of starting and growing this business that you wish you'd known then? Or kind of what takeaways would you give to the rest in the Brown community?
I guess I'll start and you two can share. For me, definitely, the biggest learning point is just talk to as many people as you possibly can and learn as much as you can. Because for us, we started our research in home health care and kind of went across the map in terms of who we were researching from. And the further we got in our bottom-up research, the more we'd hear this specific pain point. And after we heard it from 30 people, we were like, yeah, this is definitely something we should build. Yeah. And that's really what it was for me. Like, just make sure you talk to people. Like, you can't learn everything from libraries.
Yeah, for me, it's similar. I'll reiterate his point. He said bottom-up research. That's probably the most important thing to really harp on is you have to identify the pain points that you're going for when you're building and trying to build a product to help serve a problem. So bottom-up research, talking to as many people as you possibly can, as Robbie said. Bottom-up research is definitely the most important thing.
For me, I think it's just efficiency. So, you learn how to do things as you go, and then you develop your own protocol, and then it works, and then you keep redesigning it. But I think it's just important to really, really think about your methods really early on so that you can start to sort of build that, and then you'll be more efficient in perfecting it.
Being open, like as he said, being open to change and being open to switching your methods and understanding that what you're doing might be completely wrong. Being understanding to kind of changing is also very important.
I love that. And it certainly echoes, I think, which any of us who've either been involved in the business or the research space have learned, which is that you have to do your pilot studies, right? And whether those pilot studies are doing qualitative interviews, also known as customer interviews in the early phase, or whether the pilot studies are figuring out to see if your data actually works and if your modeling assumptions hold. Those are essential in terms of making those next steps, and it's okay to pivot. Again, whether it's within the research or the business space. So thank you for those observations.
So I'll ask one entrepreneurial-based question.
Yeah.
What are your thoughts on commercializing your product, and how far down that path are you right now?
Right. So in terms of commercialization, like we are obviously researching like in kind of this academic space, but we are actively selling our products, so there are people paying to use it currently. So in terms of our progress, we've ran successful pilots, we've raised funding to grow and scale this in terms of our research as well as product development. But yeah, it's really kind of hand in hand, because the more research we do, the better our product can perform. But yeah, it is a commercialized product. It's not just.
And what's your business model? What do you charge your customers?
Yeah, it's just a subscription in terms of like number of patients, and yeah, we try to keep it very simple for organizations, and we charge obviously a setup fee for us to integrate into their organization.
So I have one further question, which is about the data, and others have already asked a little. But one of the big things that I think surprises people who are starting to do this work is the intricacy of health data. I think, you know, we all hear about machine learning and big data and imagine that it should be so easy to answer these complex questions using the wealth of health data that we know is being produced and collected. I would love to hear about your experiences with actually obtaining, cleaning, and using the data that informed your machine learning models. Because I know, looking around this room, I know that there's at least a few of us that have gone through this process and can attest that it is never as simple as one imagines it should be.
Mm-hmm. Yeah, the attaining process was just first for us making sure everything was HIPAA compliant and encrypted, making sure that we were being in tune with any regulatory requirements that we had to. Isabella then worked more closely on the actual using of the data. We had a data science team and a clinical team that parsed and worked on that aspect.
One of the things that you kind of have to do with finding healthcare data is finding kind of the bedrock where things are kind of consistent across all platforms and organizations. So, and especially in EHR. So if you're looking to find like consistent things, you have to find where they're entered consistently. That was one of the most important things that we were finding.
Yeah, I think one of our early challenges was that, you know, some of the EHRs we were using, you know, it's some of the places, you know, information may be entered in one place here, and then someone else humans use data differently and their own records differently. So we had to really learn where to look and where to combine information, even where to understand that there was duplicate information. So it was a lot of just really exploring records and also understanding that, you know, it's going to be used differently no matter where you go. So you really have to adjust and pivot.
And find the ways that it's used differently.
Right.
Mm-hmm.
Along those lines, I had a question, if I can, Megan, about data cleaning. It's obviously a very detailed process, and in many ways, you can introduce a lot of bias when you clean your data. So did the people who are cleaning the data and working with data primarily have a clinical background, or no?
No, so it was our data science team, which they were students who had no expertise in clinical data usage.
The advisors that we use were very helpful.
But so the advisory we had were useful in figuring out what are the best ways for us to create this data pipeline. But the most important aspect was talking with the end user, so people who were on the data side of the provider. So where do you input data, and what do you need to see from the insights that we're providing you? So that was useful in us to find where specifically, like which exports in the EHR do we need, and how should we then present that to you, and then cross-referencing that with things that they know to be true to make sure that what we're presenting them is accurate.
I do want to give others a chance to ask questions as well. So for the rest of you that are on, is any burning questions or concerns, things that you'd love to hear Will, Robbie, and Isabella talk about? Well, so then I'll finish then with what are your next steps? So you kind of mentioned that one of them is starting to create that panel of interventions to recommend for folks that do have potentially preventable illness or ED visits or hospitalizations. What else do you see as your next steps?
I think a really big next step for us is to have more data points to work with. So obviously everything we presented was with a fairly limited data set. So if we could start working in the quantities of tens, hundreds of thousands of data points, everything we do will have just much higher efficacy. So it's finding partners and organizations that can let us work with them, learn from them, and continue our research and work. I think that'll be very, very crucial to us expanding and growing as a team.
Yeah, as kind of the model kind of self-explains, it's the models learn with the more data they have. So it's kind of like a chicken or the egg. Can we get more data to make our models better, to then get more data to make our models better?
And so there, my kind of call out to those who are on the call, if you're not already part of Intus Care, as I know a number of you are, would be to think about if you have an organization that might be interested in partnering. And then the vice versa for you guys at Intus would be to think about what the advantage is to the organization. I know that some of the early organizations you worked with were ones that you had personal connections to, and I think that that certainly is a good model going forwards, especially as a startup organization. But to think about ways that you can facilitate the partnership, whether it's things like joint grant writing, raising funds specifically to support the data infrastructure that's required, working with foundations and philanthropy to use this as a way to help them improve their care. I think one of the things that you'll find is that particularly in this era of COVID-19, many healthcare organizations are struggling and so don't have a ton of extra staff or capacity. And so in terms of kind of getting access to that data, thinking through what they get in exchange. So I'm really just excited to have you guys at this point. It's been so impressive to watch how far you've grown over the past 2 years, from those early customer interviews and figuring out your pain point to this point where you actually have models and are raising funding. So just huge kudos to all three of you. And with that, I think I will close stuff down. Laura, we saw your comment in the chat. I'll open it to Will, Robbie, and Isabella if you have final comments or questions. And otherwise, we'll sign off for the week and see many of you next week.
Yeah, thank you so
Absolutely.
much.
Yeah, thank you guys so much. Really appreciate the time.
Thank you. Thank you for the great presentation. Bye, everybody. Thank you for joining.
Thank you.